You're listening to Compliance Conversations, your inside scoop on all things healthcare compliance, auditing, and coding. Now, let's get on with the show.
Welcome, everybody, to another episode of Compliance Conversations. I am CJ Wolf with Healthicity, and today's guest is Miss Maya Turner. Welcome, Maya.
Hello, CJ. It's so good to see you again.
Yeah, it's so good to see you. We've bumped into each other recently at some conferences, had some good
Yes.
conversations, and we thought, okay, we gotta, instead of just talking between ourselves about these, let's throw it out there for the world and see what they have to say. And so, but before we get into that topic, Maya, I know you've been on the show before, but maybe just spend a couple minutes telling us a little bit about yourself, what you're doing, any upcoming projects that you're working on, and then we'll jump into our content.
Okay. Because there's so much content to discuss, I'm just going to try to keep this brief. Well, as much as I can anyway. My name is Maya Turner. I am with the AAPC National Advisory Board. I have 7 certifications that I'm very proud of. And we do a lot of work in regards to creating the venue for coders to find their ways. And one of the projects that I'm very happy to announce is that I've written a book recently called Billable, and it's called The Revenue Cycle Professional's Guide to Branding. And the reason why it's so important is for when coders are educated through the VILT program, which CJ and I are both involved with, it's important for coders to have a foundational idea of what they want to do and build on that expertise before they do anything else. And so I think this book is very important, and it's also foundational for any coder's career, for them to flourish and to build and to create relationships and to know what's good, what's not good, and the best things to go about doing things that are really foundational in the industry.
Yeah. And is the book already out, or you have a release date, or tell us a little bit about
It's been out, and to
Okay.
believe it or not, it's already been listed as an Amazon bestseller. So it's
Awesome.
really actually very cool, and I think a lot of people are locking on to it because it really talks about things that people really don't realize are important when they're starting. Because when you're a coder, you want to be good at everything, but you have to really start at one thing before you're good at something else. So that's really
Yeah.
important for me. Yeah.
Well, good. Well, maybe you can send us a link of where people can look at it, and
Oh, sure.
we'll include it in the show notes for people to check out.
That's very cool. Very cool, CJ. Because you're a cool guy.
Awesome.
Yes.
Well, thank you. And let me introduce the topic a little bit. So we were at a conference recently. I was presenting on critical care,
Mhm.
and some questions came up. And to kind of set the stage, we all should know that there's payer policy, right? What
Yes.
payers allow and don't allow. And then there's CPT guidance. And sometimes in the absence of payers specifically saying something, you usually defer to the CPT guidelines, right? And so the
Yes.
question that kind of came up had to do in critical care. I think a lot of us understand that majority of critical care is done in the hospital, right? The doctors are typically in a space where those types of patients can present themselves with critical illness or injury, but not always, right? What if they're out in the field and the doctor's on the phone? And so that was kind of the question that came up, was talking about what happens when a doctor is directing critical care kind of remotely, if you will.
Yeah.
Is that how you understood it? Before I get into the questions, you kind of correct me if I misstated the scenario.
There's a lot of terminology as it relates to how critical care is performed, and the gleaning factor is where it's performed,
Yeah.
right?
Yeah.
And I think that's where the question drove, because a lot of times the physician is at the hospital floor and they're directing via vitals, they're directing via interpretation of that's being reported or electronically submitted. And so the question came is, if the physician is awaiting the patient while they're in transport, can they report that time? And we heard lots of different opinions, and we were like, I don't know. And so that's created that whole conversation. And we were like, we should talk about it. And we're like, okay,
Yeah.
so yeah, so
Yeah.
that's kind of where that came from. Yeah.
Yeah. And we'll invite you as well. and that's kind of why I prefaced this with some payers might have policies versus CPT guidance. So if you
Yes.
have a comment, or if in the links of the show notes and stuff, you'll be able to comment and that sort of thing. So if you have a comment that, oh, well, in Arkansas, this payer says X,
Yeah.
that's great. Share that information. We want everyone to know that certain payers have certain policies. But if they don't have a policy and you have some sort of guidance or knowledge from a CPT standpoint, sure, share that as well. But what we did is we kind of went back and started reading the CPT guidelines. So tell us
Yes.
a little bit about what your initial take on that is from the CPT guidelines, and how you're interpreting that kind of unit floor time, if you will.
Well, the CPT guidelines indicate that if they're awaiting and immediately available to service the patient, but it doesn't limit to where the provider can provide the critical care service. It just says immediately available. So on page 29 of the 2025 guidelines, it states codes 99291 and 99292 should be reported for the attendance during the transport or critically ill or critically injured patients older than 24 months of age to or from a facility or hospital. For transport services, critically ill or critically injured pediatric patients 24 months of age or younger, see 99466 or 99467. And the issue was that while the patient is in transport, can the physician report the critical care services? And one piece of the critical care reference does not indicate the overall view of what CPT says in regards to critical care. So CJ and I were talking afterwards, and we were like, well, I gave him credit. And they're like, well, are you? Well, am I wrong? Oh, so we kind of went into this thing and we're like, well, let's kind of see what it says. And so when I looked at page 29 of the CPT book, it clearly says transport to a hospital as long as they're immediately available. And I think that's what coders often misinterpret and don't give providers that work, because they are intervening in a life-threatening emergency as it relates to critical care. So
yeah, such a good point. I'm glad you found that. Because in the moment when I was teaching, I didn't have that at my fingertips. I couldn't recall exactly.
but we had been doing it for so long, and we're like, well,
Yeah, it
there's
just
no way
didn't.
we're doing this wrong for this amount of
Yeah,
years.
it didn't feel right in our gut. And so,
Right,
but that's not good enough. You have to go back and then do the research, which is what you've
right.
done. And so we wanted to talk a little bit about that. Now, let me ask you too, because I came back and I started to research from CMS and Medicare, and I couldn't find anything. But again, audience, if you're aware of something specific, feel free to share. We're not saying we're the law. We're just sharing what we know at this point. I couldn't find anything from CMS that would prohibit that. Have
It
you been
doesn't.
able to find anything? Okay.
No, it doesn't. And what's really interesting is that anything that's related to evaluation and management, CMS defers to AMA.
Right.
And so when you look at the definitions that are associated in the internet only manual, that is, I believe it's chapter 12, 13. I have where is it? I
Is
have
it
the
the claims processing manual?
I think it's the claims processing manual, but don't hold me to it because there's so many. Oh, here it is. Yeah, claims processing manual, chapter 12, section 3612. And it says time spent engaged in work directly related to the individual patient's care, whether that time is spent at the immediate bedside or elsewhere on the floor unit, may be counted towards critical care time, provided that the activities are directly related to the care of that patient. So it doesn't necessarily say that how they're related, because technically you could talk to critical care's family, the patient's family, over the
Right.
phone. And
Right.
so that doesn't necessarily deal with the patient, but it is
Right.
related to the patient.
Right.
You're delivering the care that's in relation to that situation, because having that conversation with family members is part of the description of critical care
Correct.
services. So
Correct.
it does create um, some conversation in regards to how it's viewed. But if coders are really saying that you're not on the floor, you're really going to have some physicians really mad at you.
Right.
One, because if they're even if it took under, I mean, let's just think about this. Let's kind of break this down, right? If we think about how it translates to them being transported, and it's the difference of them activating trauma, right, versus not activating trauma. That's going to be the difference on the care that's immediately available, and even cause the hospital some liability if they knew in transport that this was happening and it didn't occur the way that it should, because the physician was coordinating that care and or the patient was in transport as it relates to that service. So
right. Well, and to your point, if you're talking to the family, that counts towards the critical care time. Talking to family alone won't meet critical care criteria.
right.
You still have, and I just want everyone to be clear, we're not saying that that alone counts. We're saying, assuming you meet the first definitions of critical care is 1, the patient's critically ill or injured. 2, you have done some sort of service that intervenes, to prevent, immediate deterioration, those sorts of things. As long as those things are met, and then you've met the 30-minute limit, right? What we're saying is the time that they're spending may also be added, because what we're getting at here is the injury or illness happens. The physician is guiding them on their way. Once they get there, it's typically that same physician who's doing the face-to-face right? So this is like work that's done before they get there. And so usually in these cases, the physician might even see the patient multiple times during the day. And we know that you add up all the critical care for that data service. So what we're saying is, do you also give them credit for the X number of minutes, right, that was spent in that? And what we're finding is, from a CPT standpoint, it sounds like yes. And then the question you just answered was looking at the CMS manual. The other thing, Maya, that I found was I went to the and last week, and this is gonna, I think this podcast from last week will be posted before this one will. We had Keisha Wilson on, and we were talking about telehealth.
Yes, you do telehealth and critical care. Yes.
Yeah. After that conversation, I'm like, wait, I know I'm meeting with Maya. I'm going to go check the CMS telehealth list. Critical care is on the list. So I know that's not the exact same thing we're talking about, but it's Medicare will pay for critical care via telehealth. Now, I know we're right in the middle of government shutdown and extensions and all that sort of stuff, but outside of that, they have in the past listed it. And so it's like, well, yeah, now that kind of makes sense to me.
Yeah, of course. I mean, because think about it. I mean, a lot of times the transport is where it's most critical, right? Because you're reviewing, you're thinking about the ABGs, the telemetry, all of the resuscitation, based upon the signs and symptoms that are presenting, right? And so because it's real-time life-sustaining effort that is presented, once they get to one point, that physician's work is really that physician's work, and it's legitimate. So, I mean, the fact that it almost didn't go that way or was misinterpreted, or even, because a lot of times when you're new or when you're regimented in a certain way of doing things, you don't see the broader spectrum, and it becomes like, oh, this is a teaching point, or, oh, wait a minute, I didn't really know that because a lot of people didn't really know that critical care was actually on the telehealth list. And so, I mean, okay, so the patient is on telehealth, but what if it's out of the physician who is receiving the patient? What if it's out of their scope and they have another provider who's not face-to-face, that's not on the floor? So you got to think about all of these different scenarios that come into play, that you're like, oh, wait a minute. Maybe I need to rethink this. And if CMS is defaulting to AMA for guidance on E&M and critical care, then maybe you should. So, it's a really interesting thing. So, yes.
Yeah. Well, Maya, let's take a quick break and come back, because I've got some other thoughts and questions for you. So everyone hang tight for a minute here, and we'll be right back.
Compliance is complex, which is why you should visit Healthicity's Resource Center. It features updates on the OIG's new General Compliance Program Guidance, CEU webinars, and more. Visit healthicity.com/resources today.
Welcome back, everyone, from the break. We've been talking about critical care. We've been diving deep into those critical care codes. Maya, just before break, you were talking about recognizing the work of clinicians. And so, one of the things that I know you're involved in is kind of changing culture, helping physicians feel recognized for their work. So we've talked about what we think is included in the billable time, right? What happens when we all are in agreement that something isn't billable critical care time? How do you still help the physician feel recognized for their work in that regard? Because they're thinking, look, my time is what I'm devoting here.
Well,
Any thoughts on that?
there's a lot of different thoughts on that. And a lot of times when physicians hear that they can't bill, right, it doesn't mean that they can't bill for anything. It just maybe they may not be able to bill exactly what they want to bill for that moment.
Good
So
point.
I think it's very important that physicians understand, one, what their options are. Two, they have to understand that when it's explained and you count for certain things that are not necessarily countable,
Right.
it's a teaching moment. But again, once they hear, what do you mean? Wait, hold on. I didn't say that the world was ending. I'm saying that you
Right.
can't bill for that specific thing. And because
Right.
you can't bill for that specific thing, let me tell you what your options are. Right. And
Right.
so we have to really think about the context of how we approach the options, right? Because if the first thing they do is, are you saying that I'm invalid with my thought process, or I'm invalid
Right.
with what I'm thinking? No, we're not saying that you're not invalid, but the context of what you use your validity is not applicable for this particular scenario. And
Yeah.
because of that, you want to provide the alternatives for the service that you are providing that can be built based upon what you're doing.
Such a good point. And I think if you approach it that way consistently, you
Mm.
build better relationships. Because to your point, if the first time they see you is you're coming to them saying you can't build critical care, right? Then it's like, oh, we're in a judgmental confrontation from
Yes.
the get-go. Rather than saying what you can't do, I like what you said. It's like tell them all of their options of what they can do, and then
Right.
explain professionally these are the criteria that have to be met in order to build that higher level, which is critical
Right.
care or whatever it is, right?
Right. Right.
And so all about kind of relationships and how you approach it. Are you the person of no? Because if you do that 2 or 3 times, they don't ever really want to see you because you're the
Oh,
person that always tells them what they're doing wrong.
yeah, it's
Uh,
like the finger in the face.
right?
Yeah.
Yeah. Yeah. So good point. And
Yeah.
then go ahead. Was there something else?
I was just going to say, I've seen time and time again where for coders are so rigid about what providers can and cannot do that they don't want to hear from them anymore. And it doesn't cultivate a relationship. The
Exactly.
goal is to be the voice of the provider, the intermediary between payer and provider clinical judgment. And you're not necessarily acting like a provider. You just want to understand the view so it's defendable, right? So think about you being a mom and your kid is being bad and you're like, oh yeah, he was bad. But you want to be able to say, well, he's had da 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 da. And traditional he's not, so you want to be able to be that voice of reason. If it ever came up again, you're able
Yep.
to defend them and create a rational and a engaging conversation on why something didn't happen. Yeah.
Such a good point. That's a good point of developing our professionalism. And I
Yeah.
love that. So
Yeah.
tell me then about, an ED evaluation in critical care on the same day, because sometimes a patient might come into the emergency room. At that moment, they might not be critically ill or injured. So you're doing an emergency department visit. It might turn into, and a lot of people are in the emergency department for 3 or 4 hours before they discharge them. And maybe during those 3 or 4 hours, their status deteriorates and it might go into critical care. So tell me a little bit about that.
Okay. So a lot of times, when you're dealing in the critical care health space, CMS defines that you can bill for an additional service if they're not critical at the moment and you were called into a situation. Again, they still might be at an emergent level, but that threshold of which they're threatening a heart attack or they're threatening a stroke, and the labs and all of the diagnostics are negative into them going into the stroke. Because again, you have to think about the necessity, the life threatening imminent emergency. So again, you could still bill for the critical care visit as long
Right.
as the secondary visit of the critical care nature comes up and it's documented the level of deterioration, the reason that they were called, because at the end of the day, it's all about saying the story from the time that you saw them to what's happening throughout. Now, of course, if it becomes an admission, then it all is rolled into one because of the certain
Right.
things. But again, that's for a later time. But if the physician is reporting the professional service and he's managing the emergency visit as well as the critical care, it is definitely reportable. And CMS does not have any pre-regards of how it shouldn't be reportable as long as it's documented, because it's a
Right.
story about capturing what was imminent related to death, period.
Yeah. Yep. Such a great point.
Yeah.
So, you probably do a lot of, I know you do consulting work and you have clients and then you're doing education as you already described at the beginning. So what are any self-audit tips for people who want to double check that their critical care minutes are defensible? Are anything that you come across regularly and you could give tips on?
Okay, I have nightmares of what actually happened, but I was, for a very long time, for a period of about 12, maybe 13 years, I was part of the education compliance program, and it was pulmonary, because you have pulmonary providers are always doubling
Yep.
as intensivists. And what was
Yep.
happening was they would use those two terms that we hate: hemodynamically stable. I
Yeah.
hate those two terms. Just like, why are you using and and it would be like, day 15 on event, and you're like, oh my gosh, dude, you give me something to work with here.
Right.
So so the best way to identify these types of things that happen is tell the story the way you would want your peers to hear it, right? You want to be able to tell the story. It shouldn't be inferred. So if your peers were to look at it from day 1 to day 15 and the days that turned into critical care that became stable on and off, then you're able to actually outline the terms of life threatening, right, versus stabilizing. They're
Yes.
stable, now they're life threatening. And the best way to do that is to tell the story and don't leave out details. Be
Right.
as descriptive as possible because you don't want the assumption to go the wrong way. So
Exactly.
yeah, I mean, in my years of doing that and working with intensivists, they were like, "Well, Maya, what do you?" And they were always complaining, and they'll until one day, the lead guy and CJ, I'm not exaggerating in this, did a Medicaid audit, and he passed at 100% with Medicaid
Whoa.
critical care, and he was like, wow, I don't think I would have did this without you. I was like, thanks. So, when you're able to do that and teach them from day 1 to day 15 and the entire story of how they reacted, what you did, how you did it, what was life sustaining, right? Deciding to put them on event, deciding to do whatever it was needed in order to stabilize the patient from imminent death from happening, then that becomes the difference in good documentation and bad documentation.
Yeah. And, one thing that I often see with providers who have a very, very basic or almost no understanding of billing for critical care, one of the biggest misconceptions is, oh, the patient was in a critical care unit or an intensive, care unit. Just because they're in that place doesn't automatically mean you can bill critical care. It's a good starting point, but it doesn't automatically, and it's not required for them to be in that place. And I'm going to include in the show notes a link to some OIG audits. A couple of
Yeah.
years ago, they had put on their work plan physician billing for critical care, and then they
Yeah.
actually did some audits of some provider practices that they probably identified through data analytics. And if you read those reports, you get some good insight into the point I'm trying to make. Is some of the findings that OIG had was, look, this patient, you wrote kind of what you were saying earlier, patient's hemodynamically stable, no complaints, looking good, will discharge later today, right? It's like at some point the patient either dies or gets better. And if they're getting better and you're going to be discharging them and your note reads as if they're doing great, then just because they're doing great in a critical care unit doesn't mean it's critical care. So
Absolutely. Yeah. I mean, and a lot of things, especially there's a huge difference, and I think we need to talk about this too, is when they're on ICU and they're on a ventilator, there's a such thing as ventilator management
yes,
versus subsequent care, right? Versus critical care. So
yeah,
if you're teaching your providers that they're on a vent and you're documenting the vent days and it's day 15,
right.
and then you're like trying to bill. Um, I'm sorry. Thanks for playing. We have lovely partying gifts, but this does not qualify for critical care. You may get ventilation management,
Management.
or you're going to get a subsequent visit, but you're not going to get critical care. So,
Right. It's such a good point because a lot of patients, they still might be critically ill or injured, and you might still be giving them a critical, you might be providing a service that prevents them from deteriorating. But if it only took you 5 minutes, you're not going to meet the time limit for critical
right,
care. So, no, doctor, I'm not saying this patient isn't sick. No, I'm not saying that your work wasn't life saving. I'm saying all of that doesn't meet the time threshold. And so there are other services you can bill. And so you kind of already said this earlier. It's just, approaching them and telling them what they can bill. And oh, well, when can I bill critical care? Well, when you meet this, and the time.
yes,
Then you can start thinking about it.
exactly. I mean, and Christine Hall, we both know, she always talks about what's happening today. What's happening today
Yes,
with the patient.
yes,
So if yesterday is not what's happening today, then your note
yes,
should reflect what's happening today for you to get the engaged work directly related to the individual's care, the outcome
yes,
of that critical injured patient, and what you did in order to substantiate the life of that patient who was at one point imminent death contingency. So you have to
yeah.
think about all of that and how CMS would view it if someone were to audit it. So
Yeah. And, I used to be the director of billing compliance at a very well-known and respected cancer center. And so, of course, all the docs had patients who were very, very sick. They had
mhm.
life-threatening cancer, but they weren't going to die today from it. So
Right,
that doesn't mean today's visit and every visit is a level 5 because they have stage 4 pancreatic cancer. Some patients get treated and they actually have a little bit of improvement. Everyone knows that they're still going to die within 6 months, but today they're probably not going to die. So
exactly.
that kind of reiterates the point that you were making. And so,
Yeah.
yeah, go ahead.
Yeah, I was just going to say, but I think one thing that we also need to examine is that critical care is not limited to what's happening in the hospital. Critical
Correct.
care can happen anywhere. So let's say that patient is suffering and having signs of deteriorating. They're at the doctor's office. They got to go to transport to the hospital. That
Correct.
provider has to be in line. He can't ride in the ambulance with them, but he can
Right.
direct the care and meet them at the hospital to manage that patient. So
Right.
this kind of goes back to what we were talking about and kind of further explains our point that it's not limited. It's where the provider is providing the care and the nature of the presenting problem that is imminent in
Right.
death. So I wanted to make sure
Yeah. And yeah, it's such a good point. And, I think what I've noticed over 25 years in healthcare is there's more and more urgent care facilities popping up that are hospital out, or I'm sorry, that they are they're basically place of service 11. So they're physician
yeah,
practices, they're outpatient clinics, but they cater to urgent care. And some patients go there instead of when they should have gone to the ER. And so I anticipate that, just the sheer numbers as kind of care moves a little bit more in that direction. And a lot of patients are reluctant to go to the emergency room because their copay is $150 instead of $65 at the urgent care center. Some patients might just not know and they might be directed there. You're going to see a little bit more about what you just said, where critical care could be given in a place outside of a hospital.
and I don't want to get involved in what the government is doing, but when you think about this OBA bill, right, and you
Mhm.
think about the lessening of Medicaid eligible participants, so if they can't go to their doctor, where are they going to go?
Yeah, right.
And so when you think about it from that perspective, and you think about how a lot of these emergency rooms are going to be crowded,
Yeah,
and the amount of critical care that's going to be reported, you know, it's gonna, if you're gonna take one here, somebody's got to take the brunt of what's happening somewhere
Yeah.
else. So it's just really interesting how all of this stuff is going to come into play as it relates to that, and we are going to see those numbers go up extremely high once this comes into play.
Yeah. Well, Maya, we are kind of coming to our end of time.
Seems like, gosh, it goes away so quick.
I know. We'll have you back. But any last minute thoughts or comments before we kind of shut down for the day?
Well, for the day, absolutely. First of all, CJ, it's always a pleasure. We always have so much fun, and it's always never enough time. It's never enough time.
Yeah.
But what I'd like to say is, before you tell the physician no, read the guidelines and do the research. Become a viable source of the information so the physician can come to you and be not won't say dependent, but openly receptive to the things that you have to say. But when you're so quick to tell them no, or you're so regimented in your process and you don't research beyond what you know, you don't become an asset. You become something less. And that's what you don't want in a physician relationship with your providers.
Such a good point. Great ending point. And as I started the podcast, if there's something that you know and that research you've done, or a payer that does it a different way, we'd love to hear it. We're not we're not here to say that we are the end all, but we've done as much research as we can, and unless somebody can show me something else, I think we're on pretty safe ground. So that's kind of the way I approach things, and I think you do too.
Yeah, absolutely. I mean, great minds think alike. Yours, your brain is bigger than mine, so I always defer to you, CJ. Yes, but it's always a great pleasure.
Thanks, Maya, and really appreciate your time, and thanks everybody for listening to another episode. As I mentioned before, we'll include a link to Maya's book. You should check it out. And if anyone out there knows of a guest that you'd like to hear from, or if you have a topic that you'd like to hear more about, please reach out to us. We want to make these valuable episodes. And until next time, everyone, take care.